the class. Subject.
Are you with me, class? So there's been a delay in the beginning of today's class because it's of some issue with the internet. Is everybody there? Good afternoon. I'll finish before lunch, so don't worry. We will pick up on whatever is left over in the next class. Our lecture mainly today is based on this topic called laryngeal paralysis, which is more or less acquired now because we have already finished the congenital part of laryngeal paralysis. We will be dealing furthermore with the treatment of this laryngeal paralysis in detail here. So you need to know what the nerve supply of the larynx is and its pathway to know how this can be cut off. So the main supply to the larynx, both sensory and motor, is through the vagus nerve, that is your 10th cranial nerve. So this vagus nerve has a pathway extending from your nuclei in the medulla, above that level again, and below to the neuromuscular junction where it reaches the muscles. So in any area, this nerve can be either traumatized, that is injured, or it could be compressed, or it can be encroached upon by the growth of something like a carcinoma or a metastasis. So today we'll discuss the pathway of the vagus and its branches and something about the muscles it supplies. The laryngeal paralysis proper we will discuss in the next class, next week. Yes. So the vagus as such has motor and sensory nuclei. These nuclei are located in the medulla. The important nuclei are your nucleus ambiguous. The spelling is a little wrong. The dorsal nucleus. And the sensory nucleus here is the nucleus of the tractus solitarius, also called as the tract of solitarius. So the main motor nucleus is the nucleus ambiguous. So from here, the nerve fibers which come from this nucleus are mainly motor nerve fibers. They reach not only the vagus nerve, but they also go to the 9th and your 11th cranial nerves. That will be your motor supply from this nucleus to your 9, 10 and 11 cranial nerves. But here we will limit to your 10th nerve. Okay. There is also addition of efferent fibers from the dorsal nucleus to form the vagus. This dorsal nuclear fibers are mainly related to the autonomic nervous system, and even more specifically of the parasympathetic nervous system. These fibers innervate the involuntary muscles of the trachea, bronchi, esophagus, and other abdominal viscera like your stomach, small intestine, large intestine, etc. From the nucleus of tractus solitarius, the fibers which are efferent to it, that go to it, are the sensory fibers. So sensory fibers are always efferent. Motor fibers are efferent. Efferent is coming out of, efferent is going inwards towards. So the efferent fibers of the nucleus of tractus solitarius carry sensory fibers from your pharynx, larynx, and your esophagus. These are also relayed via the vagus nerve. So this vagus nerve, to understand it better, this is your simple picture from your Dingra. So all these fibers received from the motor nuclei and the fibers going towards the sensory nucleus, they form the nerve which ultimately exits through the jugular foramen. So before exiting through the jugular foramen, these nerve cells pile up forming a superior ganglion of vagus. Just as it passes out of the jugular foramen, it forms another bulge or another ganglion, which we also call as nodose ganglion or an inferior ganglion of vagus. What is the importance of this nodose ganglion? It is that just at the inferior border of this nodose ganglion, you see that your superior laryngeal nerve is given. So this is your pharyngeal branch from the vagus. It passes through the level of your medial constrictor, goes into the pharynx, supplying those areas. So just at the inferior border of the nodose ganglion, the superior laryngeal nerve is given out. This lies medial to both your internal external carotid arteries and is in a superomedial relation to your superior thyroid artery. So from the nodose ganglion inferior border to the level of where the branches are given, this distance is only 2 centimeters. At this 2 centimeters distance, the superior laryngeal nerve divides into an internal branch and an external branch. So the internal branch, after being given, it goes along the superior thyroid vessels and it, yes. So this is your lateral view of your superior laryngeal nerve. This will be your internal branch. So internal branch has relation to that of your superior thyroid vessels. It enters the larynx by piercing the thyrohyoid membrane. So this is the lateral view. This will be your anterior view. So this is the thyrohyoid membrane. It pierces the thyrohyoid membrane and enters into the submucosal area of your piriform fossa. It traverses through the submucosal area of piriform fossa and later reaches the larynx, giving the sensory supply to part of the larynx above the level of the glottis. So supraglottic larynx is supplied by your internal branch of your superior laryngeal nerve. The second branch is the external branch. This external branch supplies only the cricothyroid muscle. Rest of all the muscles are supplied by your, rest of all the intrinsic muscles are supplied by your recurrent laryngeal nerve. So this external branch goes along the oblique line of the thyroid. So this is where you will see the oblique line of thyroid. It reaches the inferior constrictor, gives a branch, small branch to the inferior pharyngeal constrictor, and then goes further forward, supplying the cricothyroid muscle. So this is a motor supply, whereas your internal branch is a sensory supply. So this is the superior laryngeal nerve. So the rest of the nerve, after giving the superior laryngeal branch, rest of the vagus nerve continues downwards in the neck and reaches the thorax. So this course of this nerve is slightly different on the left and right side. So the ultimate branch which comes out through the vagus nerve in the thorax is your recurrent laryngeal nerve. So considering this the left side of the neck, you see that in the picture itself, the course of the vagus nerve is longer on the left side compared to that of the right side. Why is this? It is because the recurrent laryngeal nerve. So why is the recurrent laryngeal nerve called recurrent at all? So why is the recurrent laryngeal nerve called recurrent? Why isn't it called inferior laryngeal nerve? Yes? Anybody? Why is the name of the recurrent laryngeal nerve recurrent? Yes, so very good. Somebody has answered. So recurrent laryngeal nerve is called recurrent because it has a recurrent course. That is, it goes in a direction opposite to the direction of the nerve from which it came out as a branch. So if you can see, this is the recurrent laryngeal nerve coming out from the vagus at the level of the arch of aorta on the left side. So after coming out at the level of arch of aorta, it curves behind the arch of aorta, comes in between common carotid and subclavian arteries of the left side, and is going upwards again towards the larynx. So though the vagus nerve is having a course downwards, the recurrent laryngeal nerve branches from it and goes in this opposite direction. So this is why it is called a recurrent laryngeal nerve. So if there is a recurrent laryngeal nerve, there can also be a non-recurrent laryngeal nerve. So what is a non-recurrent laryngeal nerve? Don't Google it. If you know the answer, you can let me know. Otherwise, I'll be pleased to answer it myself. Yes? What is a non-recurrent laryngeal nerve? So a non-recurrent laryngeal nerve is nothing but the nerve which does not go against the course of its mother nerve. So what happens is non-recurrent laryngeal nerve is more common on the right side than it is common on the left side. So what happens? This recurrent laryngeal nerve, instead of being coming out from the nerve at the level of the right subclavian artery on right side, it comes out at the level of the cricoid cartilage itself. So it does not have any recurrent course. So it is a non-recurrent laryngeal nerve. So what happens when that is present? You will notice that there are some changes in the positions of major blood vessels also. So the right subclavian artery around which the right recurrent laryngeal nerve should hook around will be present on the left side when there is a non-recurrent laryngeal nerve. A non-recurrent laryngeal left side nerve is very uncommon, but when it is present, the arch of aorta will be seen on the right side. So instead of the direction presence on the left side, it will be present on the right side. So this is also sometimes a 2 marks question for you. So yes, so on the left side, the recurrent laryngeal nerve is given at the thorax, so around arch of aorta, travels in the tracheoesophageal groove and goes upwards towards the larynx. Here, in the shorter course on the right side, the right recurrent laryngeal nerve is given at the level of the right subclavian artery itself. That's at a higher level compared to a arch of aorta. It hooks around that, travels in the tracheoesophageal groove and again goes towards the larynx. So after entering the tracheoesophageal groove, more or less the area of entry is same. So what happens is it reaches almost the suspensor ligament of the thyroid and it enters the larynx at the Killian-Jamison's area. That is the deficiency beneath the cricopharyngeus muscle. So it enters in that area. This is posterior to your cricothyroid joint. Okay, this is posterior to your cricothyroid joint. So this is how it enters. And it might also form anterior and posterior branches, but all its branches supply the intrinsic muscles of your larynx. So another probable PG bit for you here, which won't be mentioned most times in your UG books, is the nerve of Galen. So this nerve of Galen is nothing but one of the branches of your internal branch of superior laryngeal nerve. So this nerve of Galen anastomoses with the posterior. So you can see this. This is a posterior branch of your recurrent laryngeal nerve. So it anastomoses with one of the branches of the posterior branch of recurrent laryngeal nerve to form the ANSA of Galen. This has a sensory function, not very significant, but it could be a PG bit. So these are your nerves. So finally, the conclusion here is that your superior laryngeal nerve is given at a higher level, 1. The recurrent laryngeal nerve is given at the thoracic level, 2. The course of the vagus or the entire recurrent laryngeal nerve is longer on the left side than compared to the right side. And 4 is that your recurrent laryngeal nerves have relations to your superior thyroid and inferior thyroid vessels. So that is why they are more prone to injury. 1 second. So they are more prone to injury during any pathologies of thyroid or during surgeries of the thyroid gland. So what are the muscles of the larynx, or what are the intrinsic muscles of the larynx specifically supplied by these branches of the vagus? So this is the explanation. You want to read it, you can go through it. Yeah, so there's been a mishap. I've been clumsy enough to cut and paste my presentation into my pen drive and later format my pen drive. So I haven't realized that I've lost my presentation until 10 minutes before the class. So this is just some random presentation I've picked up from the internet. So please bear with me. I'll come up with a better presentation in the next class. I've just managed to add a few pictures in the presentation, but that's all the time I could find before the class. So forget the PPT, but just tell me what are the muscles, the intrinsic muscles of the larynx, which are supplied by your superior laryngeal nerve. So instead of that, tell me what the abductors and adductors of your larynx are. So what is the only abductor? I have the PPT in front of you. So what is the only abductor of the larynx? Somebody answered PCA. Short forms. Okay, anyway. So the only abductor of the larynx, that is the muscle responsible for moving the vocal cords away from each other and opening the larynx wider, is your posterior cricoarytenoid muscle. So as the name suggests, it is attached to the cricoid cartilage and the posterior surface of your arytenoid. Yes. So this is a muscular process of your arytenoid. So what happens when this muscle contracts, this arytenoid turns to twist. So arytenoid is a particular joint. So you might think that when this goes closer, this whole part should go close. But what happens? This posterior process goes inwards and this vocal process goes outwards. So it twists like a screw. So when that happens, what happens? This contraction leads to widening of the vocal processes and hence causes abduction of your vocal ligaments or your vocal cords. So what are the adductors? The names are right in front of you. So these are the adductors of the vocal cords, mainly your transverse arytenoid, lateral cricoarytenoid. One will be your thyroarytenoid externus, and even some amount of cricothyroid muscle has adductor function. So the transverse arytenoid is nothing but the muscle in between the arytenoid. It cannot twist the arytenoid because it's present throughout the surface in between. So what happens when it goes together? It gets the vocal processes also together, hence adducting the vocal cords. Adducting means nothing but bringing close together. The next is your lateral cricoarytenoid. Same like the twisting action, this muscle is attached to the lateral surface. So this muscular process is pulled out laterally, hence the vocal process twists inwards, so causing adduction again. Okay, so transverse arytenoid and cricoarytenoid. And there is also a part of the thyroarytenoid muscle. So thyroarytenoid muscle is in three parts. Vocalis, which is a thyroarytenoid internus. There's an externus part, which is a main adductor here. And there is a third part, which is your thyroepiglotticus, which shortens the vocal cords. So the adductor function is for your thyroarytenoid externus. Yes. And also some amount of your cricothyroid muscle, which is a tensor of the vocal cords. So these are your adductors. Next is the tensors of the vocal cord. These are your cricothyroid muscles and your vocalis. Vocalis is again a part of your thyroarytenoid muscle. And last two muscles, or the combined effort again, will be the muscles which are involved in the closure of the inlet of the larynx. So these will be your oblique arytenoid and your aryepiglotticus. So they close the inlet of the larynx during swallowing. So these are the muscles of the larynx. So what you have to realize here is that whenever there is a combined paralysis that is combined paralysis of both the superior laryngeal nerve and the recurrent laryngeal nerve, you will see that the entire muscles, entire intrinsic muscles of the larynx are paralyzed. First thing. So when there is a solo paralysis of only the recurrent laryngeal nerve, that means this recurrent laryngeal nerve supplies all the muscles except, yes, except cricothyroid. So this cricothyroid is the tensor of the vocal cord. So there is tensor of the vocal cord and also an adductor. So it has this adductor function. So the cords will more or less be in a median or a paramedian position. We will discuss these positions in the next class. I'm afraid that detail is not there in this presentation. So, and whenever there is a singular or a just superior laryngeal nerve paralysis, its supply to posterior cricoarytenoid is lost. That means abduction of the vocal cords is lost. So vocal cords remain in adduction. They're more closer to each other. So when there is too much adduction, what happens? The inlet of the larynx becomes very narrow and it can cause some amount of stridor and difficulty in breathing. So the simple kind of treatment for this kind of laryngeal paralysis is whenever there is an over adduction, that is the vocal cords are coming too close to each other, we would like to lateralize the vocal cords. Okay, so whenever there is an over abduction or when the vocal cords are not coming close to contact with each other even during respiration or coughing or during speech, what happens? We will do medialization of these cords. We will discuss this in the next class. But right now, I would like you to revise upon the pathway of your vagus. So vagus nerve is sort of, I'm not sure if it's a very important question for you in undergraduation, but in post-graduation, it's a pretty important topic both in Viva and in theory. So you need to know the pathway, you need to know its relationships with the carotids, the thyroid vessels, how it enters and what it supplies. So just read up on the course of the vagus nerve and read up upon the intrinsic muscles of the larynx. We will discuss about this in the next class. I think it's about lunchtime. I'm sure everybody of you is looking at your watches. And I don't have much of PPT for you to show also. I can go on speaking, but I'm sure you would like to see some pictures also. So we'll go ahead and stop the class here. I'll continue with the main part of the laryngeal paralysis in the next class. The introduction is as important as the class itself because without knowing the pathway of the nerve, you won't be able to understand why any particular disease will cause any kind of compression or paralysis of that particular area. So if you can see more or less if the thyroid anomalies are the ones which are causing laryngeal paralysis, it more or less doesn't tend to affect the superior laryngeal nerve because that branch has been given at a upper level. Okay. So we will discuss it furthermore. Read it up, and if you have any doubts, ask me in the next class. I think the next class will be next week or the week after. I promise to come up with a better presentation. This is just something I picked up from the internet in the last minute with a few pictures added. So I'll get back to you in the next class.